Facelifting techniques have evolved in the last 10 to 15 years, and the outcomes are getting better and better. However, the quest for the perfect facelift is a never-ending quest. Today, we're going to discuss with Dr. Sozer, a colleague of mine who is a plastic surgeon in El Paso, Texas, his latest technique called the Glide Lift. And we look forward to hearing the pros and the cons of this technique and the types of outcomes and the kinds of patients that he selects to have this procedure done. I find that innovative techniques are not something that are easily introduced into the professional world. It takes courage, and it takes thought, and it takes a lot of hard work to kind of perfect new ideas and introduce them and successfully execute them, just like anything else. Any other great ideas in the world take time and effort to execute, and I think you are one of those people who are willing to put yourself out there and not just repeat the same things that have been done over and over again. And as you know, facelifts have gone through, in the last 30 to 40 years, have gone through many evolutions, from skin-only lifts to periosteal lifts to deep plane lifts to extended smash lifts, smashectomies, and so forth and so on. And there are advocates for each one of those procedures. And one of my friends has said, you know, in good hands, you get good results no matter what procedure you do. But I would like to know a lot about this glide lift in particular, and how it interacts and how you're able to accomplish what you can through small incisions. So with that introduction, I'd like you to tell the audience, who are both professionals and patients, what your approach is.
Sure. Well, thank you for the opportunity. And it all started, actually, I was in Sao Paulo, Brazil, for a conference at a friend's house. And they introduced me, actually. He sat next to me, a plastic surgeon named Andre Oswald. He is the plastic surgeon who developed this surgical net, all these sutures from outside, basically closes the dead space. It was mostly developed to prevent hematomas after facelift. And,
Right.
but of course, a scary look for the patients and everything.
Right.
And
When I gotta stop you there. When I first saw it, I said, "There's no way that any of my patients are going to go for that." You know.
I know. I did.
And
So when we were having dinner, Andre shows me a picture. I said, "Oh my God, you are the crazy guy."
yeah,
So
yeah,
as I came back, I'm operating, I'm doing a facelift. Let me try this. It takes me forever to place the net. It looks
yeah.
horrible. And then, but the patient healed very well, and the result was so very good. There were no suture marks. So I
Uh-huh.
started doing it. And then a good friend of mine, his name is Fausto Viterbo, and another Brazilian plastic
I know
surgeon,
Fausto. Uh-huh.
and he developed the gliding bra lift.
Right.
Gliding bra lifts basically is a concept to one tiny incision. You infiltrate the skin with a tumescent solution, which is a solution for people who are not doctors, with local anesthetic, water type of thing. You kind of expand this area. Then with
Right.
blunt instruments, you detach the skin. Once you detach the skin, with sutures, you kind of cinch it and move the bra up. So it's a simple procedure you can do under local anesthesia, and you can shape the bra. It's a powerful procedure because most of the procedures are targeting a bra lift, but sometimes, and not every patient needs a bra lift. Sometimes they need bra shaping. So if you detach the skin and you're putting sutures, so you can elevate this, put one suture here, this portion, another. So you can really
Uh,
shape the
manipulate.
bra rather than just elevate it, because an endoscopic bra lift is just gonna elevate this way. Sometimes patients look good, sometimes they look like a McDonald's sign. So I started with this, but the procedure has limitations because not everybody has a large area over here. Some people have low hairline, is very close to the bra. So the skin that we can really use to redrape and elevate the bra in some patient is limited. And
Hmm.
also because we are not removing any skin, so with some patients, I would see some, like when you look carefully, little like irregularities and little wrinkling. So yes,
Hmm.
I had my share of great results and my share of not so great results. Uh, and then I said, well, how can I change that? Okay, I'm gonna say, I decided making my incision over here a little bit bigger. I was putting a small offrit lithotractor that we use in rhinoplasties
Hmm.
and looking inside, dissecting this portion of the face. Uh, uh, then I
Under
said,
the skin? Under the skin? Just under
under
the
the
skin?
skin,
Oh,
subcutaneous. But
okay.
then also, I wanted to increase the surface area that I can manipulate. So I said, how can I include this into my dissection? So when I pull the skin, this is perfectly pulled, but the loose skin is bunched up in the hair that nobody sees.
Hmm.
So, but I did a lot of endoscopic surgery. If you go deep, there is a structure called deep temporal fascia. There are
Right.
no vessels there. It opens up very easy, but that's a deep dissection plane. But the other one under the skin is a superficial dissection plane. They don't communicate.
Right.
But then right in the hairline, sometimes with electrocautery, sometimes it is interesting. You have to see a video. I could stick a liposuction cannula in a subcutaneous plane. I have a tiny incision here. When I stick it, I would take a triovicral suture and tunnel it this way, and then come through the deep, come out, and get the other end. So I would loop the triovicral suture like this. Then I would use it like a saw and divide this tiny tissue separating those two planes. All of a sudden, I had a dissection of all this area where I can move this and then put the loose skin in the hair. So I would have no bunching up, no wrinkling in this area. I
Okay.
called it extended gliding brow lift.
Oh, extendable. Okay.
Okay, so this is kind of evolution of the procedure. And then, well, I'm coming this way. Well, I want to kind of move this up. How can I move this up? So I started taking a suture and doing suspension sutures from the SMAS to the deep temporal fascia. So I would shape the bra very nicely, then suspension sutures to here.
Right.
And
Right.
suspension
But
sutures,
that's been done before. I mean, that
yes,
was done. Yeah.
that's been done before.
Yeah.
But I was doing it through the tiny incision, no
Okay.
skin removal, and gliding the skin upwards
I
and
see. I got
securing it with surgical net. That was not done before. Uh,
it.
and then I wanted to really shape the periorbital area as a unit, like really the shift of it. And I was coming with my dissection very close to the lateral orbital rim, to the corner of the eye, but the skin over here is very thin. And the dissection over there, over this muscle, orbicularis oculi muscle, is very difficult. And even if you successfully dissect it, uh, you get some color changes.
Hmm.
And that is not nice. So what I did, I came all the way here. Instead of going under the skin, right here, just only on this portion, I got under the muscle. I got under the orbicularis oculi muscle. That put me right on top of the periosteum. And I was able to actually very nicely visualize the superficial canthal ligament all the way
Hmm.
from here. But
Uh-huh.
to better visualize it, my incision was like this. What I did is I just made the incision a little bit bigger.
Oh,
So I go in this way, and I could put a bigger lighted retractor all the way here. When you do that, you're only 4 or 5 centimeters away from the corner of the eye.
okay.
And through that dissection, I could really disconnect all the superficial attachments of the canthal ligament. Of course, the canthal ligament, I'm not detaching, but I'm just sweeping off the orbital rim right here. That
Okay.
will give a very powerful rotation to the eye when I am
Mm.
doing the procedure. And with
Yeah.
some patients, I went in and took a bite from the canthal, superficial canthal ligament and secured it to the superior orbital rim. And some patients, actually, I took the bite, then I held up the canthal ligament, divided it, and sutured it. So I was doing pexies,
Oh,
cantoplasties through a tiny incision here.
okay.
So I changed the name. I said this is gliding periorbital shaping because the shape change was very powerful.
I see.
And
Got it.
and then again, doing these cable sutures, I was not 100% happy with that.
Yeah.
Now, and also at the same time, I was doing deep plane facelifts. And as you
Right.
know, deep plane facelift, you get under the smash like this, and
Right.
you pull it. Even if you do an extended smash, you come like this, you pull it. All
Right.
of them, they give great result right here. And you have a beautiful jawline, you good correction of the middle of the face and everything. But
Right.
it always lacked in the periorbital area. You could never effectively shorten the distance from the eyelid to the cheek because this is a vertical movement.
Right.
And
Right. Right.
sometimes some young patients come to you and say, Doctor, I'm not ready for the facelift. Can you just do this for me?
Yeah.
This is like 40 years old, 45 years old, and they don't want the facelift incision yet. So now I cannot do the deep plane. My cable sutures are okay, but how can I really elevate this? Because I have this zygomatic retaining ligament. When I'm trying to pull from here, this is not moving.
Yeah. Yeah. Yeah.
So I said, okay, how can I eliminate the zygomatic ligament? Okay, so if you pull from here, zygomatic ligament is in the way. But what if, with my subcutaneous dissection, I come like this and create a cul-de-sac of subcutaneous dissection? So I'm right on top of what we call this malar fat.
Hmm.
And now the zygomatic ligament is right here. If I move this upwards, I'm not pulling this way. Zygomatic ligament has no restricting function. I can freely move this. Actually, it moves all the way down here.
Okay. Okay.
Okay, so what I did now, here, I am under the orbicularis oculi muscle. I have the periosteum exposed.
Mm.
Instead of cabling all the way down here, I can just grab this right from here and suture it to the periosteum of the lateral orbital rim.
Okay.
It's right there, very short distance. The
Okay.
shorter the distance, the most effective the plication, the suspension, everything is. It's a
Right.
simple rule.
Hmm.
So I would get a barb suture. It's a 2O PDO quill barb suture.
Hmm.
Take a bite, periosteum, go take this, move on. Then take another bite, very close bite from the periosteum, grab this, move up. And
Mm.
three bites. And then I would walk that suture to the deep cervical, the deep temporal fascia. It
Hmm.
has two needles, and I would come. So I had a very successful elevation of this malar fat. Effect, it will completely uh, correct the nasolabial fault, even
Mm.
have effect all the way to the jaw through a tiny incision here.
Mm.
So
Good.
that, and now I called it, now it's a glide lift. So
I see.
gliding brow lift became extended gliding brow lift. Then
Okay.
extended gliding brow lift became gliding periorbital shaping. And
I see.
then it evolved to become the glide lift procedure. Then
I see.
you redrape the skin vertically with these net sutures and put all the excess skin in the hair. And in
Yeah.
there, you get a bunch up. That bunch up, I would put a big suture, 2-O-Proline, and put it in that fold and leave it there 7 days, and the fold would disappear as well.
Oh,
So
will. That was a question of mine about when I didn't get to talk to when I did interview Dr. O'Daniel, and I didn't understand the gliding brow lift pushes everything up subcutaneously, but then I
yeah,
would think you'd have a fold up here of redundant tissue. Isn't that
yes,
correct? And
okay,
what happens to that redundant tissue?
okay. So the gliding procedure
Yeah.
proposed by Fausto,
Yeah.
Jerry O'Daniel uses my technique, elevates this hair right now.
Oh, okay.
Okay, so it is cinching. It is cinching and cinching and cinching.
Right. Right.
So you're depending on contraction, cinching and thinking that you cinched, those little wrinkles will disappear in time. So it wasn't like everything is smooth. This is cinched, this is cinched, this is cinched, this is cinched, bunch of cinches. And
Right.
then this is elevated. But as I mentioned, not all the time that those little cinching disappears creates a wavy look. And
Ah,
that's what I didn't like. But
I
when
see.
you give it, if you dissect all this tissue so you can pull and give all that excess skin to the hair, it creates a fold in the hair, then a
Okay.
big suture. You just go over that fold and leave it there for 7 days, it disappears. What
Ah,
happens is with this gliding procedure, you if you look carefully, you will see a change in the hairline
oh,
as it
okay.
moves back.
Okay.
But it is so minor.
Okay.
Nobody complains about it. But if you put two pictures together,
Okay.
that answers your question. That's where the excess skin goes.
Yeah.
The
Yeah.
hairline
Well,
goes back.
but I was attracted to this. I'm very interested in this procedure in particular because there are patients who have very high foreheads like mine. I mean, I'm bald here, but I'm just saying, like, if you do any other procedure, you may move the hairline back, whereas the gliding, because you're making small incisions in almost in a little bit behind the hairline, you're not moving the hairline that far back, correct?
So, I mean, if you have a big forehead,
Yeah,
now you have enormous amount of skin to redirect it.
right.
That makes it a perfect candidate for the original procedure,
Which is,
which is just cinching like, but
oh yeah, okay.
now you're
Oh,
not
that,
limited
okay.
to
Yeah,
a
yeah, yeah,
tiny
yeah.
amount of skin.
Yes,
Now
yes,
it is all the
yes,
way
yes.
here. That
Yes,
opens up big possibilities for you. You don't need to elevate the hair and all that stuff
right,
because
right.
now you
You're
have a
talking
large
about people
surface area.
with narrower a narrower.
Exactly. Narrowing
Forehead.
down, then you have a limited amount of skin
I
to
see.
kind of redirect.
But but in those cases, the recession of the hairline is actually favorable in a sense, isn't it? Is it not?
The original procedure, yes, but
I'm talking
if
about
you
yours.
no, mine, I mean, yes, my hairline moves slightly backwards, but it's in millimeters, really. You cannot
Okay,
see it. It is so
okay,
tiny. I
okay.
mean, when you think about brow elevation, it is not centimeters anyways. It is millimeters.
Right, right.
As an ophthalmologist, probably you've done direct brow excisions. Is that right? Like direct excision
I
brow lift,
never
no?
liked them. Never liked
No,
them.
they
Never
haven't
liked
liked them. But
them.
they still use it, and I have friends like famous plastic surgeon Giovanni Botti, Mario Pelle. They don't do any kind. Even young patients, they do it. But at the end of the day, you're removing like 5 or 6 millimeters of skin. So when you redistribute it and move the hairline a little bit back, the movement is in millimeters. So it is
Yes,
not,
yeah. It's small. It's
yeah, very
correct.
small. Yes.
I do primarily endoscopic brow lifts, but anyway, that's my preference. But I am very interested in your new technique. So now, do you do deep plane facelift as well?
Okay,
What are you
now
doing? What are you doing on the neck and the mid and the lower of the face?
okay, so I was doing the deep plane. So
Yeah,
now I'm doing this procedure for the last 7, 8 months, and I love it. I think my results are pretty good. I call it a hybrid. So I have my facelift incision. So I
yeah,
have total exposure.
yeah.
Through my facelift incision, I'm doing the same dissection. I'm getting under the orbicularis occlusi muscle, creating the cul-de-sac, Where
Mm-hmm.
the cul-de-sac ends, this subcutaneous dissection, the deep plane starts.
Oh, okay.
So what I'm doing through my open facelift, I'm suturing this to the corner, to the periosteum. So I'm
Right.
getting a vertical lift. And
Right.
now for this portion of the face, I'm deep plane. So I am
Okay.
going using plication and deep plane at the same time, different
Okay.
vectors. This is vertical, this is oblique, and
Okay.
I'm calling it a hybrid facelift.
I see. I get it. I get it.
So I call it a zygomatic retaining ligament sparing deep plane because when I do this, I don't have to detach the
You're not
zygomatic.
messing with it. Yeah. Do you have any, I mean, you're subcutaneous. You don't encounter any nerves, only
No, I'm
sensory.
under the skin. Yes.
Right. I see. Okay. And how about on the neck? What do you do in the neck?
Uh, well, I
You,
do very complicated
do you have to
surgeries.
do a very deep neck dissection and celery, submandibular gland, uh, either, what do you do with the submandibular glands, for instance?
Well, I live in El Paso, Texas, and my patient population is a little bit different than up east in New York. I operate a lot of heavy faces, and so they require an aggressive approach. My rate of submandibular gland removal is over 90%
90%.
or
Wow.
95,
Oh,
almost
wow.
everybody.
Oh, okay.
So,
Oh,
but I used to do it with electrocautery.
yeah.
Nowadays, I use a device called ligature.
Yeah. The ligature. I know what that is.
Yes, and I have a
That
visiting
seals off that seals off the gland so it doesn't ooze, right?
exactly, and there is no bleeding. It's very clean surgery, and also
Yeah.
there is no heat dissemination. It's a very powerful bipolar. It
Yeah.
can cauterize a 7 millimeter artery at 200 systolic pressure.
Wow. Wow. Oh,
So
wow.
gland is nothing. You just go through it. I have a doctor visiting right now from Mexico, plastic surgeon. I told him, I said, look, I'm going to remove the submandibular gland in 3 minutes. That's how long it takes.
Wow, that's great. But
Yeah.
are you concerned about nailing the marginal mandibular nerve in there, or
Actually, the concern is the cervical branch of the facial nerve that
Okay.
runs in the capsule.
Okay.
Marginal mandibular is next to the facial artery behind. It's very difficult to get to it. You
Okay.
will injure the marginal mandibular right here under the
Yeah.
gonial angle where it is superficial. Then it comes, goes behind the gland and comes, and you can hit a terminal branch if you're trying to detach the mandibular retaining ligament.
Right.
So some people, they come a lateral approach and remove the salivary gland from the lateral approach. In
Huh.
that approach, more likely to injure the marginal mandibular because
Okay.
they are coming from behind.
Right. I
When you
got it.
come from the center, the marginal mandibular is away, but you will get, if you're struggling, you will get retraction injury, or
Hmm.
if you get into a bleeder, heat dissemination injury to the cervical branch.
Oh,
What will give it? It will give you a lower lip dysfunction. We call it a dysfunction. So
right.
two muscles here, the depressor angulioris
Right.
and depressor oris labii inferioris, DLI. It's a
Hmm.
triangular muscle.
Yes.
So when you hit the cervical nerve, the corners are symmetrical. So you tell the patient, do this, they can depress both corners.
Uh-huh.
Show me your lower teeth. When they try to show the lower teeth, one side moves down, the affected side stays up. So
Yes.
that's a DLI malfunction. But
Okay.
100% of them temporary
It's,
because there is
I've
so
seen
much.
permanent ones. I've seen permanent ones.
Yes,
Listen,
I mean, it
I
happens.
practice in New York City. I see permanent ones.
But maybe it's a marginal mandibular.
Oh,
Marginal
okay, maybe.
mandibular
But
is
they've gone
permanent.
through the center. They've gone through the center to attack the salivary gland,
Yeah.
and I see some permanent weaknesses in the mouth.
Yeah,
So
I mean, anything can happen. Anything can happen, but it is the incidence is low. What I'm trying to say, the
okay,
permanent,
okay,
and
okay.
it comes back very easy.
Okay.
Because if you injure a cervical branch, it is like the buccal branch. There are a lot of, it's not like if you go around to the fat pad, uh, the buccal fat pad, there's the superior inferior buccal nerves. You get one of them, the other one takes over.
Yeah, yeah,
And
yeah.
and cervical, there are like 4 or 5 of them coming this way. So
Okay.
they take over. But marginal mandibular single nerve, you get it, it's
Yeah.
gone.
Yeah, yeah. And how long does it take to recover after those
Okay,
cervical?
when I started
Yeah.
these aggressive neck surgeries,
Yeah.
uh, I mean, the patients were in pain, and the recovery, once 2 or 3 weeks, they are very functional. But the feeling, but then, you know, I started using Exparel, the
Hmm.
long-lasting local
Okay.
anesthetic,
Exparel? Uh-huh.
Exparel. And then I mix it. It comes in 20 cc's. I
Yeah.
mixed it with 1 cc of Kenalog
Uh-huh. Uh-huh. Okay.
and 40 milligram per ml, so 40 milligrams of Kenalog
Yeah.
and 20 cc of Exparel. So you
Okay.
remove the gland,
Yeah.
you inject little Botox in it, like 15 units,
Yeah.
and then you inject Exparel.
Oh,
Like
okay.
you remove the digastric muscle, you inject Exparel in it. You
Oh,
do
okay.
your platysmal plication, you inject Exparel in it.
Oh,
You do your lateral shaping sutures, you inject Exparel. At the end of the surgery, you inject Exparel anyway,
wow.
everyone.
Really?
My patients, I don't remember the last time we gave any narcotic in the recovery room.
Uh-huh. Interesting.
And really, in 1 or 2 days, everybody is taking only Tylenol.
Huh, that's great. That's great. Yeah, that's great. Well, listen, what I'm amazed is that you're see what I here's something that really intrigues me is that so many innovations occur. I know that you're Turkish, correct?
Yes,
Well, it seems that that people who have kind of grown up in the American system are tied to tradition and they're afraid to move out of that corridor.
yeah, I can see that.
You're constantly trying new things. You know what I mean? You are trying to push the boundaries of what you can do, and that's remarkable to me. I mean, I think it's a remarkable thing. I think it's because of the fear of the medical legal system. We have less innovation, and to me, the innovations that you're talking about, and kind of the bravery to go beyond the limits of what other people have done is has to do with I just think that it has something to do with you know your background. You know what I'm saying? And I mean, where did all the innovations recently come from? Brazil, from you, from from other people, of course, in the United States who followed suit. But I mean, a lot of the innovations are coming from people like you who are trying to push the envelope, and I applaud you for your courage in a sense.
Yes, I guess we are courageous enough to be immigrants. It is not easy when you're young, living in your country, and make a decision to move to a totally different country, which the language is your second language, cultures
Hmm.
and everything.
Yeah,
Uh, it's kind of a personality thing, I think. So
yeah.
I left Turkey when I was 24 years old and came
Oh,
to residency to the United States,
I
which I
see.
think was the best decision in my life, by the way. I
Uh,
love I love being here.
Uh-huh. Well, that's great. Well, listen, I thank you for your time and your insights, and I can only applaud your further explorations. Did you ever, before I leave, did you ever try any subcutaneous dissections in the neck, for instance? Have you ever tried doing anything there where you don't have to do deeper dissections there in terms of
I mean,
accomplishing?
I it depends on the skin laxity. Everybody gets this full dissection for sure, but should I go all the way down here to the sternal notch type of thing? Sometimes they come very strong central bands going all the way to the sternal notch.
Yeah.
If you don't splicate it all the way down here, they will come back,
Uh-huh.
recur. So
Uh-huh.
I do extended skin dissection on those patients, or
I see.
sometimes very, very loose legs. Then you have to really uh, detach and redrape that skin, which the
And
surgical net helps
the
because you can,
surgical net, the net
yeah,
that you
with
put.
the surgical net, you can really perfectly redrape it. And also
Uh,
another thing nowadays I do is to give in the definition of the gonial angle. Uh, I may sound crazy, but I remove the tail of the parotid now, not complete removal, just little shaving, 60% of the time.
really? You don't get like effusions over there from the
Xylomas,
yes,
yes. When I first started, of course, all the improvement comes because you have a problem, then you try to solve the problem. And
yeah,
so I had a patient, I mean, she had a huge, like this was like this. So I kind of shaved, basically it's an enlarged gland. You're reducing it to the normal size. You're not doing a formal parotidectomy. But
right,
then I closed the capsule on top of it. And then I had a collection here. She came, she had a surgical net. I removed the surgical net. 4 days later, she has like a seroma. Okay, I aspirate, is watery because the xyloma of the parotid is different than xyloma of the submandibular gland. Submandibular gland is very viscous.
hmm
This is like water.
hmm
And so, but I figured out it is saliva. What I did, I aspirated it. I injected 50 units of Botox into the gland. I put a
yeah,
scopolamine patch. I put the patient on a diet, and I put a separate surgical net on top of it, kept it as for 7 days, solved the problem. And then I decided, well, I don't want to have this problem again.
yeah,
So when I removed the parotid, when
yeah.
I put my surgical net, on top of the parotid, I put a separate color net. Like if I'm using blue suture, I use, for example, transparent suture. My nurses know that different color net is not going to be removed in 2 or 3 days. It's going to stay 7 days.
Oh, I see, I see, I see, I
So
see.
by
Oh,
doing so, I
it's all
eliminated
external
that
though. It's
problem.
all external. You don't do it internally or anything, right? You
No,
don't you
I
don't
mean
put a net.
internally you repair the capsule, but it is never watertight. But really, putting that surgical net eliminates all that saliva collection problems.
Oh wow. Okay, that's great as well. That's another good tip because I've seen cases like that as well.
Yeah.
Okay, well, thank you again for your time. I appreciate it tremendously. It was a pleasure having you on as a guest, and I look forward to watching your further developments as they evolve. Thank you again.